good to be here again. And my task this morning is a little easier than on Thursday, where I needed to get 16 hours of material into 2 hours. I tried to limit this conversation to adult ADHD because I think it's both contained and it answers a lot of the questions people ask, what can I do if patients can't afford testing? We'll flip back and forth because everything we're talking about will be relevant to kids, but we're going to explore ADHD. So this is me. You've seen this, and we'll start off with Alex to give you a flavor of what we're seeing with adult ADHD. So I didn't know Alex when he was a student, but he went off to college. I knew his family. I saw one of his other kids, one of the parents' other kids. So he went off to college, and he started having difficulty paying attention. So he went to the counseling center, and guess what they did? They gave him Adderall, and they kept increasing doses of Adderall without a comprehensive assessment, with no history of school learning. Probably he was actually a bright student in suburbs of Boston. So he started taking high doses of Adderall, and he started getting agitated and anxious and not sleeping. So the school psychiatrist prescribed Xanax. So then he was getting anxious during the day, so he was taking Xanax during the day with his Adderall and Xanax at night. When you go to college, you're an adult, so you don't have to talk, the physicians don't have to talk to your parents. And so he got home at the end of freshman year extremely malnourished, not eating, anxious, and popping Xanax all day long. So we see him in the office, and I do routine blood draws, and he was deficient in most nutrients, iron, zinc in particular, serum levels, B12, hemoglobin, hematocrit, and this was a gentleman who was not a vegetarian and eating regularly. So celiac screen, antibodies positive, biopsy positive. He developed celiac disease. Okay, treated the celiac disease, ADHD disappeared. Again, we talked about it earlier in our review. Any kind of rapid train to malnutrition is going to produce symptoms of psychiatric or sometimes attentional, sometimes mood symptoms. So we need to be kind of careful as we think about adult ADHD. More times than not, there's underlying physiological causes. But I always start off talking about ADHD with a little history. I think we can do this for any major psychiatric disorder, but the history is always fun and interesting. So we've been describing hyperactive, impulsive kids at least since the 1800s, right? There's a poem called Fidgety Phil. How many people have heard of that poem? Oh, good. Fidgety Phil was a German psychiatrist who wrote about this boy in the illustrated poem about being fidgety and unable to sit still at the kitchen table. But then we started naming this. And from the 1900s, we had defective moral control, right? And then after the flu vaccine, we started the flu epidemics. These kids looked like that, so we call it post-encephalitic behavior disorder, and then brain injury. And then I think we felt bad for the kids, so we started saying minimal brain injury. And then we said, okay, well, it's not really damage, it's dysfunction. You get the idea, right? We keep changing the name of this disorder, and from DSM-3, 4, 5, from hyperactive, inattention, 2 different diagnoses, now to DSM-5, which is ADHD. I think this historical journey is only relevant, and we can translate it to much of our mental illness diagnoses, is we're just naming things without having any concept of etiology, and based on what's happening in our culture, the name is changing. To me, I think it's pretty clear that we do understand ADHD, and that's what I want to talk about. Although we understand it differently from different countries. Anybody from France here? Okay, but I mean, France and the U.S. are the most dramatic, but every country has different rates. The U.S. tend to have the highest, but look at some of these numbers. We have either somewhere between 11 and 15% in the U.S., 6% taking medications, with less than 5% in France. And then, more global differences. There's some concept of you are not allowed to prescribe stimulants to children in France under 6. And part of the reason I wrote this book, but I used to give talks on ADHD in the 1990s. I had ADHD clinics. And the reason I wrote this book recently is that, one, I'm more concerned about these 3- and 4-year-olds put on stimulants. And you'll see, here's my favorite, antipsychotics. So these are research studies done by our colleagues in the world of child psychiatry looking at risperidol for ADHD in children under 6. So I felt there was a tremendous need to try to educate our colleagues in how we can treat ADHD in both kids and adults. So when we talk about ADHD, some interesting studies, and we can thank our pharmaceutical companies. But as we change the diagnosis again from DSM-4 to DSM-5, we make the diagnosis broader, and that helps some people, but more the pharmaceutical companies. As more people have a name, more people can take a medication. But just going from DSM-4 to 5, we go from 12% to 21%, 65% increase just by changing the criteria. So you begin to see how powerful that book is. Was it Gray, I think, right? That Gray Bible that defines how we practice medicine is just growing exponentially with new names, which means new drugs. But I don't think it's a fad, and what I'll share with you now is how disabling adult ADHD is. Most kids continue to have symptoms with social, emotional, academic life challenges that I'll talk about. The core symptoms we're all aware of, I think, in this: the inattention, the impulsivity, the overactivity. As we get older, and sometimes for females when they're younger, it's not a hyperactive behavioral discontrol, it's more of an internal sense of restlessness. But there are two terms that have been very helpful in my career in understanding this disorder and helping patients and families. One is this variability in performance, right? I think I have a slide. Think about a variability in performance. So this inconsistent production. So if somebody can get their homework done one day or get their job done one morning, and then they can't for the rest of the week, for some reason we have this kind of feeling that they can do it, they're just faking it. It's not a neurophysiological process. But variability in performance is actually a hallmark of ADHD, that inconsistent ability to sustain attention. And this one, difficulty with rule-governed behavior. This is both good and bad. It's good for our entrepreneurs and our people who are taking risks, and many of you who've stepped outside the box. It's not good in other areas of society, but knowing what to do versus doing what you know. Most of our ADHD adults could write books of what they should be doing and how to organize their day and their life, etc., but they just can't do it. So difficulty with rule-governed behavior. And the consequences of untreated ADHD, I believe, are tremendous, both emotional and behavioral disturbances. Let's just look at some of these, right? Fewer years of schooling, lower occupational attainment, more divorces, more marital stress, substance abuse, and actually research with higher mortality rates, untreated adult ADHD. And then we get to life-threatening behaviors, driving. How many people have heard this? More traffic accidents, more tickets, more anger and aggression. We'll get to it. And then there was one case that looked at insurance claims, much higher insurance claims with those with ADHD. And then the driving piece gets a little more concerning when sober adults with ADHD drove similar to intoxicated controls. So for our safety, we want to begin to address the treatment for adults with ADHD. So this is a new study last year with outcomes, and again, just a broad stroke of higher psychiatric comorbidity, anxiety, substance abuse, conduct disorder, and then the punchline here, lower life satisfaction, lower job preparedness, and depression and substance abuse. So we need to do something. Medication is an alternative. It's something that I have not thrown away my prescription pad. I feel very strongly in two subgroups, our younger kids under 10, that are 12 even, that we very rarely need medicine, and most of the time our adults, I believe we rarely need medicine if we can look at integrative approaches. For some of our really disabled children in the prime of academics, sometimes medications can be used short term. The interesting piece about medication is in our children. This slide doesn't make sense. It didn't come out the way I wanted. But the punchline is, in our children, the boys have much higher rates of stimulant use. But in our adults, it's the women. Okay? Women have much higher use of prescription stimulant medications than men for the treatment of ADHD. Okay, so this is where we start my journey. I think I actually had hair when I started those, so otherwise, that's pretty much what my life was like when I came out of practice, 1989, child psychiatrist, and everybody who knocked on the door had ADHD. I mean, it's just what you see, certainly in the 80s and 90s. And we had, one parent, fix my kid. I need that drug that my neighbor is taking. Give it to me now. And then there are parents who would never give their kid a medicine. Now, some of the parents who wouldn't give the kid a medicine, they might be taking 3 antibiotics for their ear infections and another pill for this pain, but, something for their brain or behavior they wouldn't take. So, early on, as I shared with the group earlier, I went into medicine thinking I was going to cure the world with brown rice and kale, and then got kind of waylaid, for 9 years turning out as a psychopharmacologist. So very quickly, I realized the limitations of medicines, the side effects of medications, and got back to my roots. And so 2 things happened. One, as a child psychiatrist, and the reason why most of us can't do it full time, is it's hard to deal with the mothers and the fathers. I don't mean to pick on mothers, the parents, I guess. So I had a few pushy parents telling me about this supplement that cured their kid of ADHD. And you listen, and you say, okay, and you move on. But after about a year of being told by a number of parents about OPCs, and then these 2 books came out, and I started doing my research and reading, and that's what I want to share a little bit about with you. How many people know about OPCs? Great, okay. How many people have used OPCs for attentional problems? A couple of you, okay. Well, OPCs, I only say it once because it's too hard for me to pronounce. Oligoproanthocyanidins. I did it, right? Okay, so we're just going to, did I get right? What is it? Oligomeric. I knew I missed the Americ. Oligomeric proanthocyanidins. So OPCs, trust me. Okay? So it's these beautiful colors in our foods. The blue in blueberries, the red in grapes, green tea, dark chocolate. Flavonols are the big category, and there are hundreds of different molecules. And the history is interesting. Jacques Cartier, who was an explorer, his shipmates had scurvy, and the Native Americans were able to cure the scurvy by just using some of the bark from the pine trees. So in the late 40s, Jacques Masquelet from France, a PhD student, read these journals and couldn't understand how you could cure scurvy from bark, and he started looking and isolating OPCs. At the time, vitamin C was was isolated by Gorgie. So the work that I want to share with you is OPCs, these beautiful, colorful phytochemicals, if you will, has been shown to be incredibly helpful for ADHD, both in mood, alertness, impulse control, aggression, grades, self-esteem, and attention. And there's a pretty vast research. I only will share bits and pieces with you today, but it's really both fun to read and pretty simple. But I know a number of you are biofeedback people. How many people have done neurofeedback here? Oh, wow, you guys are way ahead of me. Okay, so I did neurofeedback in the 1990s in the office and became quite fascinated and interested, and that's what we're going to chat a little bit about first, is neurofeedback for the treatment of ADHD. And the punchline is going to be OPCs act as this neurofeedback-like mechanism that works very quickly and less expensive. So the concepts of neurofeedback, we need to do a little exercise in EEG and brainwave studies. So there are two brainwaves that are important. If anybody's paying attention this morning, we're using what brainwaves? Beta. Okay, so these short little brainwaves, when you're paying attention, is beta waves. And if you're daydreaming and thinking about lunch or what you're going to do next, you have more theta waves. Okay, so theta is daydreaming, beta is attention. That's going to be our theme for the next 15 minutes. So guess what? We have data since the 1990s that have continued to come out that those with ADHD had this increased theta to beta ratio. Okay, so think about it for a minute. ADHD, not able to sustain attention, much higher theta waves compared to beta waves. A number of studies demonstrating that ratio. And in the office, one of the first things that we did at the time is just look at individuals hooked up to the EEG machines and just looking for that ratio. And it was really dramatic of how you could predict how high that theta-beta ratio was, really helped predict the severity of symptoms. But there was a norm, and it was predictive. And then we have research saying that ratio is predictive across the lifespan of ADHD. These were studies with adolescents, adults, and kids in controls. So we have this elevated theta, low beta, and so neurofeedback, and I was really fortunate enough to work with the grandfather of neurofeedback, Joe Lubar, who really started this, and he helped me get set up. And the research over the years has gotten to the point where our pediatric community, the same community that voted that it's okay to give amphetamines to 4-year-olds, has given neurofeedback their blessing as level 1 best support for ADHD, right? So that's the good news. And then as research has continued, and I don't want to go too far on neurofeedback, but we have comparisons with methylphenidate, so Ritalin. So we have decent studies that show that neurofeedback was as effective as Ritalin. And then the important part, whenever we think of an illness and when we ever get stuck in our medical model for psychiatry, which is just symptom-based treatment, right? You're depressed, you have a symptom, we're going to give an antidepressant. You're anxious, we're going to give a benzodiazepine to treat those symptoms. Well, we're able to, and then you don't take the medicine, the symptoms go away. For the neurofeedback, the research looks like improvements were seen at 2 and 6 months of follow-up. So by getting at some of the underlying cause and changing some of these EEG patterns, we can make sustained changes in the brain. And then here, quicker and greater improvements. This was a 6-month follow-up as well. So another study done, 2014, 6-month follow-up. Okay, so with my theta, beta information, running this ADHD clinic in the 1990s in a suburb of Boston, I contacted Joel Lubar, and I told him, I'm using this supplement, and it's really helping. And he said, well, let's try to prove it. So research is not my thing, so he helped me set it up. And don't laugh, because these slides were done in the 1990s. But, you know, I probably had 40 or 50 cases that we worked together to look at what happened when OPC was integrated into an ADHD treatment plan. We did adults and kids. It's effective in both. The reason why I'm focusing on here today is because with the adults, it oftentimes is the only intervention needed. For kids, sometimes we'll talk about many other things that are going on. So remember, our daydreaming brainwave is what? Theta, so that's red, okay? And we did 3 different tasks. Baseline, they were just staring at the computer. Reading, we gave them something to read. And then listening, okay? So these were the 3 tasks here. And then with OPCs, we saw kind of dramatic decreases in theta wave. And then if we separate the baseline, this was just staring. You can see the theta being very high. And with the OPCs, the theta waves went down. And then in reading, which is even more dramatic, one of the fascinating things when you and I, or many of us, go to read a book, our beta waves increase because we focus and we pay attention. But it is so painful, particularly when you're looking at the screen and you watch these kids try to read, or some of these adults. The opposite happens. Their theta waves go up. They just can't pay attention. So here you see OPC's pretty dramatic decrease in reading. So we have adult studies. We had different variations. We sent a paper to the American, what's it called, the American Journal of Child Psychiatry, and got a little, they wouldn't take an article, but they, a letter to the editor, after there was a couple other letters to the editor in the 90s of child psychiatrists using pycnogenol and other OPCs for ADHD. So it was getting written about, and every time something like a nutritional supplement gets written about in a traditional journal, it's a little better now, but all through the 90s, early 2000s, there always had to be an editorial, even for these letters to the editor. And guess what the editorials had to say? We need more data. Yes, this is interesting, but, and in the same journals, there were psychopharm studies with 9 patients, all right? And this is an effective drug for the treatment of schizophrenia. And anything that was published with a nutritional intervention, very interesting, but we need more data. Really, really frightening. So that's my journey into research. The career was brief, but powerful, and really changed kind of how I thought. So this theta-beta ratio is very powerful. Many of you do neurofeedback. You understand it's a training program that just works. And I stopped doing neurofeedback at the time, primarily because insurance didn't cover it. It was expensive. And I couldn't guarantee patients got better. I think the programs are better, the system is better. But I stopped doing it in the late 90s when I found OPC to be as effective. So we have 2 different ways to affect that theta-beta ratio. One is neurofeedback, and the other is OPCs. So what I want to kind of share with you a little bit is kind of how some of the mechanisms for OPCs affecting attention and ADHD. And one, we saw decreased theta waves. Haven't seen much other data or research to support it, so just kind of my clinical trials in the office in the 90s. But we have pretty significant antioxidant activity, moderating catecholamines, affecting the blood-brain barrier, affecting allergies, decreasing copper, and working as an antihistamine. So let's kind of take that journey for a little bit. So in France, actually, OPC products are used as pharmaceuticals. And they're used, I think the indications are hemorrhoids, for those of you who are interested. But what these OPCs do, they enhance the integrity of the cell wall, the blood cell wall, so that it's firmer. So it cross-links the collagen and hence enhance the integrity of the blood vessels, so hemorrhoids are decreased or prevented, but it also helps the blood-brain barrier. And I think this is a tremendous neglected area of both research. I think we're getting into it a little more with some of the infectious interests that we're talking about. But for food allergies and toxins, the integrity of the blood-brain barrier, I think, is really critical, and OPCs enhance that blood-brain barrier. Particularly food allergies, our child work with ADHD. I think Dr. Shaw is going to be talking about food allergies. Certainly kids under 12, food allergies have a major role in ADHD. I find it less kind of critical as the kids get older and into adulthood. It's still a variable, but we don't always see the dramatic shifts. But for some of my kids under 6, under 7, sometimes eliminating the food allergen is 90% of the battle for their ADHD. Doris Rapp. How many people remember Doris Rapp? Oh, wow. Started talking about this in the 1980s. I'm sorry? Is she still alive? Really kind of popularized it and helped people understand your child that got the red faces and the red ears and the black eyes and the behavior changes after food. It could be a food allergen, mostly IgGs. When you look through the literature, even though our pediatricians and our scientific community will still say there's not adequate literature, there is, and there's pretty good research out there looking at EEG changes when you're allergic to food, elimination diets, and then reintroduction related to behavior problems. But we can use the elimination diet, we can minimize those foods, but OPCs act as antihistamines. It's incredible for seasonal allergies, but also the food allergies. So OPCs inhibit the histidine carboxylase so we can lower histamine in the body and help allergies. OPC is an incredibly strong antioxidant, more so than vitamin C or vitamin E. This is one study looking at DNA damage and OPCs being able to reduce oxidation and DNA damage. Glutathione, a randomized controlled child on children with ADHD. This was pycnogenol, pine bark. Most of the earliest studies were done with pycnogenol, 1 milligram per kilogram, and OPCs promoting healthy ratios of glutathione. So then urinary catecholamines. Here, this was a study on 57 kids. The norepinephrine concentration positively correlated with degree of hyperactivity. OPCs were able to decrease the norepinephrine and inhibiting that oxidative stress and normalizing catecholamine levels. So OPCs have a broad range of cognitive effects affecting allergies, blood-brain barrier, and I believe one of the more important ones is its effect on copper. So whenever we talk about ADHD, certainly for many, many years, we were able to say check lead levels because the incidence of lead in ADHD is dramatic, 40 or 60%. So it took a little, no, not a little, a major tragedy, a public health problem to get us aware of toxic heavy metals in our water supply. So Flint, Michigan kind of opened us to at least think about this. And we know that any lead level has dramatic increases in ADHD. This one, 155% more likely to be diagnosed with ADHD. For those of us who have been doing this for a while, we've watched, acceptable lead levels go from 10 to 9, 8, 7, 5 to 2 to pretty much anybody in the field is reporting there's no safe lead level that doesn't affect brain behavior. But after the Flint, Michigan case came out, the state of Massachusetts, where I'm from, decided to test the waters in their school system, which was great. I think they did 120 communities and like 1,000 tests. And not only did they find high levels of lead in the drinking water of our elementary schools, some a few miles from my home, but thankfully they looked at copper levels, and copper was even more dramatic. So let's see if I have my copper slides. Well, and this we talked about on Thursday. As copper levels go up, zinc goes down. So I'm quite convinced, and the literature goes back many years, that high levels of copper is a major contributing factor to ADHD in children and adults. High copper kids typically are irritable, aggressive, and invariably these are the kids that have the poor response to stimulants. Okay? Now the stimulant efficacy rate is pretty high. It's pretty dramatically high. And that's why our pediatricians continue to prescribe it and parents continue to ask for it. Some are between 70 and 90% in some literature for getting side effects. But you get that subset that have this kind of irritable, angry, bad reaction to stimulants. There are two things to think about. One is elevated copper, and the other is elevated levels of HPA. Have we all heard about that from our organic acid lecture? Okay, so I would say in my experience, 90% of kids that have a poor response to stimulants in terms of increased agitation, they have elevated copper or high levels of HPA. Both induce this kind of artificial elevation of dopamine levels, and then you're adding a stimulant and it just feels really bad. Okay, so you need to check for both. But the copper is really important as one of our major treatments for both adults and kids with ADHD is kind of rebalancing this zinc-copper ratio and increasing zinc levels. So we're using zinc, again, not mega doses, 30, 60 milligrams for kids, up to 90 milligrams for adults when we're trying to decrease copper. For some of these kids who need medication, oftentimes if we use zinc for perhaps 3 months and someone reintroduces a stimulant, sometimes they can tolerate the stimulant without those side effects. Okay, this talk was on OPC, so we're not going to ignore that. But OPCs are grapeseed extract and green tea and pine bark and red wine. It also decreases the copper zinc ratio. And this is just one study done a number of years ago, but we have many other studies looking at OPCs bringing down copper. So the zinc work is pretty impressive. It's as impressive as I think some of the antidepressant and depression literature. And this is just a summary of some of that literature. So we have research, many have done by Dr. Arnold, psychiatrists in this country, zinc levels predicting stimulant response. So those with very low levels didn't have as good a response to the medication. Statistically, those with low levels of zinc, a much higher incidence of ADHD. And those supplemented with zinc had a response comparable to the stimulants and reducing hyperactivity and impulsive behavior. Zinc levels we talked a little bit about earlier. Serum zinc is helpful, but not usually. I look at copper-zinc ratios in the hair. There are functional markers of zinc deficiency. Functional meaning what kind of metabolic process is going on that can help us understand zinc is not adequate. And my experience has been low levels of alkaline phosphatase, low white blood cell count, Okay, and why low alkaline phosphatase is really important? Because if we're a growing adolescent, our levels are going to be dramatically higher. They're going to be 500, 600, or 1,000, so much higher than the norm. So if some of our kids coming in with low alk phos or not matching growth, that is a functional marker of zinc deficiency. We can also look at the zinc taste test. How many people have heard of that? Good. I mean, that's fun to do. We used to do it all the time in the office or in the hospital. So you're just taking a zinc sulfate solution, a few teaspoons, swishing it around in your mouth, and it should be a strong, bitter taste that you just want to spit out if you have adequate zinc. Why? Because your taste buds are zinc-dependent enzymes. The gustin is a zinc-dependent enzyme. If you taste, or the adolescents or the adults, they swish around this zinc solution and it tastes like water, it's unlikely they have adequate zinc. And so if water is 0 and spitting it out is 4, we have a scale of 1 through 4. So the zinc taste challenge is kind of a fun, certainly helps the skeptic and the parents or the patient to begin to believe, because over time, they also will want to spit out the zinc. Okay? Make sure you give them a little cup, though, because it is a strong, bitter taste. So zinc copper is really critical. People ask how long elevated copper levels for our ADHD kids and adults can be sustained for long periods of time. There is a not uncommon kind of relapse part of the process, similar to what we would refer to as the die-off with treating candida. So these kids are doing okay for a month or 2, and then they get worse. So again, copper is stored in our tissues, and the copper coming out too quickly, there's an exacerbation of symptoms. I've had some kids where we've just stopped zinc for a week and they did fine. Other times it took longer, and then much lower dosages. Elevated copper sometimes can take 6 to 12 months. And so for our patients that are looking for that quick fix, for our practitioners that are looking for that quick fix, decreasing copper in an ADHD child patients is really critical. That's why doing other kinds of both nutritional interventions, vitamin C and OPCs to help bring down copper as well as zinc. Okay. We talked a little bit about this earlier, but the other part of zinc is it blocks the dopamine transporter, which enhances dopamine in the synapse. So we have multiple mechanisms of why zinc can be effective. And, I also use this slide to kind of help us kind of look at the big picture of ADHD. So not only we talked about on Thursday, do we need the amino acid precursors and all the cofactors to synthesize dopamine, but then we have our body's need to break down dopamine by COMT and monoamine oxidase enzymes. And these are all kind of genetically determined and driven. So our ability to break down dopamine is based in part on some of the polymorphisms of our COMT enzyme. So those that break down dopamine very quickly, it's called the Val-Val variant of the COMT gene, they are, been shown to be responders to stimulants. I'll show you, I think, also responders to some of these other interventions we're going to talk about. But they also might need higher dosages. Those that have the MET variant of the COMT gene often have side effects to stimulants, which means I'm much more aggressive with my alternative, I can't use the word alternative, I'm sorry, with my integrative therapies. Okay? So if we just take a look again at this picture, there's a lot of things that go into helping this young child or this impaired 21-year-old who's trying to get a job after college pay attention. And the Finely Focused book that we wrote tried to outline all the variables that we need to look at to help these kids and young adults focus and pay attention. So some of it is dietary, Some of it is understanding the genetics. Some of it is understanding the heavy metals and where we need to be aggressively treating. Here, just overall attention, one of many studies, but this was 2011, 53 healthy students. This was 100 milligrams of pycnogenol, pine bark for 8 weeks, decreased anxiety, and improved attention and cognitive ability. So again, none of the research was done with pycnogenol. Sometimes pycnogenol is expensive. I didn't say when I got started, we used pycnogenol, we used grapeseed extract, we used red wine extract, and in our experiments and what I've been doing for 20 years, I've just had much more success, and I can't explain it, with mixed OPCs. So formulations that have combinations of OPCs, probably because we don't really understand the 100, if not, if there are any biochemists in the room, there are probably thousands of flavonol molecules. So I just got much more dramatic results from these mixed OPC compounds. So we're using combinations of pine bark, grapeseed, red wine, green tea, and things of that nature. Okay, so then, you know, beyond pycnogenol, and here we had our blueberry concentrate. This was a randomized controlled trial with 26 adults, mean age 68 years. And this was 1 ounce of blueberry concentrate, which is a very, you know, concentrated source of OPCs with improvement in fMRI scans and cognitive tests after 12 weeks. And here we have the results of those studies: working memory, better perfusion, better in cognitive tests with OPCs, or blueberry concentrate, which is a strong source of OPCs. Okay, so OPCs is kind of step 1 for our adults with ADHD. Again, we've talked a lot this weekend about testing and objective testing guiding our treatment models, and that is my preference. OPCs, there are no tests we need to do. We can add it to any supplement regimen for our adults with ADHD. But for those of you who aren't sick of me talking about lithium, lithium is another very simple intervention for adults with ADHD. And it's not as profoundly effective for our inattentive ADHD individuals, but it's those individuals, men and women, with irritability, with road rage, with impulsive, aggressive action. So think of irritability, anger, impulsiveness, and think of the low-dose lithium. I think we're all familiar when the parent brings a child in for their ADHD evaluation. By the end of the first evaluation or second one, there's usually 1 or 2 parents pointing at each other saying, "Oh, I guess that's me too." And again, that irritability, anger piece is often not treated because people kind of say, "Oh, that's personality." They don't quite get it. If these adults were smart and they found the right job or the right spouse, you know, the ADHD symptoms don't become as dysfunctional as some of the symptoms we talked about early on from the research. So they kind of live with it, but low-dose lithium has been particularly helpful. I showed this slide on Thursday. I don't believe in God, but I believe in lithium. A woman who found dramatic relief with bipolar illness, but developed chronic kidney damage and needed a kidney transplant. So we cannot, you know, very hard to use high-dose pharmaceutical lithium for periods of time. So we're talking about nutritional lithium, low doses. For our ADHD kids, we're using 500 micrograms to 5 milligrams. For adults, I'm using 5 milligrams of orotate to 10 milligrams. We're using the lowest effective dose that works. We rarely get any blood levels. We rarely got side effects. I described in the Thursday talk. The 2 side effects I've got was one physician who felt too calm and didn't like the feeling, and another adolescent that said she just felt spacey and didn't like the feeling. She might not have had breakfast that day, but those are the two comments that I've gotten. It's mostly positive. When we look at lithium for ADHD, I described earlier that there are three things we look at. One is a trace mineral hair test. So a number of the labs do test for lithium, some don't, so make sure they do. So undetectable lithium on a hair test, to me, is significant. Doing the test for 30 years, I'm seeing more and more undetectable lithium, and whether that's from the bottled water we're drinking or some of the other kind of heavy metals or toxins or fluorides that are binding or getting in the way of lithium absorption, who knows, but I'm seeing it more. The second thing we look at are those clinical symptoms. I might not use nutritional lithium for that inattentive kind of space cadet concept, but I would for that irritable, impulsive patient. And then family history. I know I said that a lot on Thursday, but I can't say it enough. Family history of aggression, family history of substance abuse, family history of bipolar illness, and family history of suicide. You might only get one of those. 2 suicides in this family that nobody talks about. Substance abuse is very common. You have to ask the questions. And you have to go through 2 generations. And that's how we're looking at lithium for adults and kids with ADHD. So we have different kind of dosages for lithium. Again, our colleagues are frightened of lithium because it is a toxic in high dosages, so you can die from overdosing on lithium. So that's our 2,000 plus. Our therapeutic doses as psychiatrists are somewhere between 600 and 2,000. I haven't used over 600 probably in 10 years. So my therapeutic doses are 1 milligram to 300 milligrams. I believe we have kids that are deficient. We have adults that are deficient based on that symptom complex. But I also believe, just based on my clinical experience, that we have individuals that just need a higher maintenance dose, and that's based on that family history we described. In this talk, we don't have time to go over the incredibly numerous effects of lithium on brain function. It affects all the major neurotransmitters, decreasing dopamine and glutamate, increasing GABA and serotonin. It stimulates at least 50 genes. It is a powerful epigenetic molecule in the brain, and the most significant one for me and for us here is probably stimulate the synthesis of brain-derived neurotrophic factor. Lithium has been studied for, here's my last slide, dementia, Alzheimer's, Parkinson's, ALS, for our purposes, aggression, ADHD, and think about the public health implications of child abuse. As a child psychiatrist, it's one of the kind of horrors and tragedies of my life and career, but who is hitting their kids, right? I mean, it's usually someone who does not have control of their impulses. There's often an underlying psychiatric illness, major psychiatric illness, but oftentimes it's ADHD. It's out of control ADHD. They get angry like we all do, but they can't control it. So lithium, I think, has profound implications. There was actually studies looking at child abuse, and the women taking lithium was not lithium orotate, it was actually prescription lithium, but the women taking lithium had markedly less physical aggression to those in the family, and then reached out for support more on lithium, and a bipolar diagnosis was excluded. So part of the problem of talking about ADHD is that we have so many different images in our head. We might think of our spouse as being inattentive and not, following through. But we have to think about the child abuser, the prisoner, more aggressive forms of poor impulse control. And we've all seen them respond to psychopharmacological measures, but I believe there's tremendous room for nutritional interventions. So the last kind of big picture concept of adults with ADHD, we could go on and on with the kids. but without testing, and I think Dr. Brown, last year spoke a little bit about rhodiola, but it's an incredibly helpful herb that we use for ADHD, but as psychiatrists, I urge caution, because I've seen just as many side effects, probably more side effects with rhodiola comparable to St. John's wort than I have with any other nutritional supplement. But let's get to our punchline. I mean, there are a number of studies. This is one, 17 to 19-year-old kids, 100 milligrams a day, stressful exam periods, with improvement in well-being. We have a number of studies with rhodiola, nicely outlined in Dr. Brown's book. The problem when you look at the research on rhodiola is you're going to have one study with 100 milligrams, and you read the next study, it's 620 milligrams. Have you noticed that? And then who do you believe? What do you do? And you can't say this works if we have multiple dosages. So reading the literature on rhodiola kind of gets you a little excited, but you're not quite sure where to go. So let me give you my clinical experience. I've used it a lot. I've seen great results, and I've seen someone admitted to a psychiatric hospital for bipolar illness taking rhodiola. Let's start there. I would not recommend rhodiola for someone who's bipolar. And I say that as a global statement. If you did, you would use low doses when somebody is perhaps in a depressed phase. It supports dopamine synthesis. It keeps dopamine around a little longer. But the person that ended up in a psychiatric, I've had two actually, one St. John's wort and rhodiola taken on her own, and the other one was just rhodiola. And so with bipolar patients, I would be using kind of minuscule doses for someone in the depressed phase, watching it very carefully. For ADHD, I'd start off with 100 milligrams. I've rarely got above 400 milligrams. It's not a big supplement I use for kids with ADHD, but it's a nice supplement for the college kids I don't want to use stimulants with, or for adults. And I use between 100 and 400 milligrams. I start with 100, maybe twice a day, 100 BID in the afternoon. Sometimes it impairs sleep. For depression, I've gone up to 600 milligrams with good results. For ADHD, I hover around 400 milligrams. Go slow, titrate up. That is my rhodiola story. We'll have plenty of time for questions. I think I'm way ahead of schedule here. I think we went through this already. So, in summary, here's our integrative medicine for mental health concept. For all illnesses, here we're talking about ADHD. We know there's some imbalances, dysfunction of our neurotransmitter systems. I'm not sure we can accurately predict, but we can come close to understanding it. And our goal as clinicians and scientists is kind of improve symptoms by balancing that. And there are many ways to do that. We can enhance precursors and those nutritional cofactors. We can help the neurotransmitters kind of stay around the synapse longer to do its effect. And that's where you see some of the phytochemicals, rhodiola and green tea kind of prevents reuptake, and some of these enzyme modulators kind of preventing breakdown, curcumin and quercetin. So we have these kind of physiological, phytochemical, and nutritional interventions to optimize neurotransmitter synthesis. But we have a whole host of other interventions, that I just want to spend a few minutes talking about, because we talk about integrative medicine, and this conference does a great job at focusing kind of on the biochemical and the testing, which I think is the foundation. But then we have that other concept that we talked earlier about, not just nourishing the brain, but nurturing the mind. So what many people don't appreciate, for our patients with ADHD, there's incredible literature on mindfulness and mind-body techniques. So we put these kids in yoga classes and mindfulness programs, walking nature. We see dramatic improvements in attention and focusing. Okay? Mindfulness for ADHD, There's a few good books out there. It's really simple. These kids love it. They might not be able to sit and meditate, but walking meditations, mindfulness, doing stuff they like, and it could be anything from fishing to video games to, playing sports. But mindfulness training has been very powerful with really very good research in ADHD. We talk about attention deficit, but I really think the reframe is, different deficits, nutritional deficits. The one I didn't talk about, which is the core part of the Finally Focused book, is magnesium deficiency. I believe magnesium deficiency is common in many major psychiatric illnesses, anxiety and depression, but I can say emphatically 99% of our ADHD kids are deficient in magnesium. It is truly amazing to me. It's regardless of diet. I believe there's something genetic, because no matter what they're eating or doing, they are all low in magnesium, and they all benefit from magnesium. And part of that gets into our other common concern with ADHD in adults and kids, which set up this very disordered circadian rhythm cycle, is sleep deficit disorder. There's a really dramatic research looking at kids in the first 6 months of life with sleep problems, irregular breathing that were measured, and then they monitored for 7 years, and really dramatic incidence of ADHD in those kids with early disordered breathing. I rarely have ever met a child walking into the office with a parent or an adult with ADHD saying they sleep well, right? They fall asleep without a problem, or they don't wake up, right? Is that your experience? So sleep is critical, and I think we do whatever we can. It's sleep hygiene, getting them into the bedroom, but oftentimes their brain is going. So we use a couple things to support sleep deficit disorder. One is the magnesium, the hallmark supplement for ADHD. 2, melatonin sometimes can work, sometimes it can't work. There's some research studies looking at melatonin ADHD for sleep, which was fairly positive. But we also use inositol. Inositol has not been helpful for the treatment of ADHD. It was actually studied, double-blind, placebo-controlled trials. So it doesn't help the ADHD, but I use it in the evening for some of these kids that are just start worrying, whether they're worrying about their homework or what they're going to wear tomorrow, and they start worrying in the evening and they can't sleep, so it's keeping them up. And again, our goal is to get these kids to sleep, because that pattern, when it starts early in middle school and it goes through high school, is just devastating, both on brain function, contributing to inflammation and a host of other problems, and certainly ADHD. So we use whatever it takes, nutritionally, magnesium, glycine, melatonin if we need to, and oftentimes inositol. And it's not inositol right before bed. It's inositol, 6, 7 o'clock, quarter to a half a teaspoon, a couple grams, and then maybe again before bed. And invariably, these kids will just say that the obsessive thoughts are less. And these are not kids diagnosed with OCD, although sometimes early onset OCD is part of the problem. So we talked about nutrients, we talked about sleep, and then what about respect? So many of these adults and these kids that I'm seeing with ADHD are so demoralized. They spent their entire life being told what? They can't do it, they're a failure, they're dumb, they're stupid, and they believe it. And that's how they're kind of going into adulthood. And it's really important that we kind of provide strength-based treatment approaches. Ned Hallowell does a great job, and we actually have a video conference available about his kind of positive reframe. And whatever it takes, going through a historical review of all the famous entrepreneurs and inventors and scientists that were ADHD to help kids feel better, to help adults career choose based on their symptoms. Because we're not going to medicate a hyperactive ADHD kid to be an accountant, but we might help them become a CEO of a company that they believe in. So emphasizing the strength, minimizing kind of these deficits, and not using medication as this kind of straitjacket. Again, I have not thrown away my prescription pad. There are kids that are really struggling where we needed to use medications. Let's say in high school they're failing. While we're doing these nutritional testing, while we're bringing down copper, we're not going to have these kids continue to fail. Low-dose stimulants to get them feeling better, and then both the child and the parent can really appreciate a tapering off of the stimulant when they don't need it. So oftentimes, hence integrative medicine, we're looking at pharmacological interventions with nutritional interventions. My last medication comment is stimulants cause some side effects. The most concerning would be psychosis and paranoia. We see it occasionally, but if we start off with low dosages, we don't usually see it. But what we see is irritability, agitation, insomnia, nail biting, and those are all tics. Those all disappear with magnesium. So I've never started a kid on amphetamine or a stimulant supplement without using magnesium with it. It really minimizes almost all those side effects. The only side effects it doesn't minimize as dramatically is the decreased appetite. And the last respect story I didn't get is for those parents is it doesn't take research, but we happen to have a lot of research that those parents that are overcritical, these kids, guess what, don't do as well. So when I started and these hardcore behavioral management programs, you know, and we punish the kids and we start removing stuff from their rooms, I swear to God I had someone came into the office that everything was out of this child's room except for the bed and the mattress. And that discipline stuff does not work. Okay? Setting limits is appropriate, behavioral management is appropriate, but really that respect, that listening, helping these kids understand the disorder is critical. So you have much to learn, my son. You can't say on with his head after you said off with his head. Okay? The consequences of untreated ADHD are real, and we need to appreciate it. You know, the long-term outcomes we've talked about, the public health implications, the self-esteem and emotional and career. And I think the punchline that most adults will share with you is never living up to their potential. And I do think an integrative approach, I'm confident that we can treat ADHD. This is a full-day video that we did, Dr. Shaw, Dr. Hallowell, and myself. And so it's on demand, and it's really a 6-hour CEU conference. And finally focused is the book, and got plenty of time for questions. Thank you.